I want to just briefly introduce everybody. Dr. Bente Mikkelsen, who is the Director of the Division of NCDs and Promoting Health through the Life course. I want to ask you what that actually means in a moment, if I can. And then Carmen Auste, who is an old friend of Economist events, Vice President and co-founding member of Cancer Coalition Philippines, as well as co-founder and chief executive officer of Cancer Warriors Foundation, and a prominent figure in the NGO and the space in the Philippines, which has really prompted and the legislation, the new Cancer Act that's come into place there. Lots of interesting things to discuss there. Jeff Sturchio, who is the CEO of Rabin Martin. I hope I pronounced that right, not wrong. And a global health, that's a global health strategy consulting company. And last but not least, Dr. Ahmedin Jemal, who is the Scientific Vice President, Surveillance and Health Services Research, the American Cancer Society. Thank you for joining us. So we're going to have a brief discussion around some of the key multi-perspective issues that are raised by our various speakers, and then Dr. Jemal is going to give us a brief presentation. Bente, can we start with you? First of all, just tell us quickly, as I asked you right at the beginning, what does it mean, the Life, the director of Division of NCDs and Promoting Health through the Life course?
So thank you for asking this question. I mean, that is a delightful thing to be director of, because it's actually from childhood to aging, and also sort of integration of all the different NCDs into other programmatic areas. So right. We work across the Life course with mental health, with child and adolescent in settings like schools, cities, prisons, and so on. So it's given opportunity to address also cancer in a different way.
I hope our Life course doesn't necessarily involve prisons. But
you never know.
Well, thank you. You have a lot of confidence in your moderator. I want to come back to this, this question that was raised at the beginning with Francesca, only briefly with Francesca Colombo, and that is inequities in NCDs, in access to NCD treatments. And I suppose it's counterintuitive to think of the Euro area, which is the area that you deal in, having significant inequities. But tell us a little bit about those inequities and tell us why they're there.
So first of all, I think people, when they think about Euro, they think about the European Union, which is not the region for WHO. We have 53 countries. So we have all the Central Asian, the Balkans, the Russian Federation, and also the EU. So obviously, this is maybe the most sort of inequate regions of WHO. So on that basis, we have for the last 10 years actually then tried to, in all we do, reduce inequities. So we have worked through a framework called Health 2020, which is very similar to what you can now see from the SDGs. So just this year, we were able to present a report on inequities in the region. And you would be pretty surprised, I think, to see that many of the inequities has not changed over the last 10 years, even if we can see some improvement. And the most concerning, very much linked to cancer, is the out-of-pocket payment, which is still between 7 to up to 60, 70% for health in general, and we see very high numbers in cancer.
So that obviously applies to specific countries in the your Euro region. Can you tell us which countries those are? And
so not only specific countries. I think this lens has also made it possible for us to look into every country. So, okay. As you know, I mean, NCD is driven by poverty and it drives poverty. So NCD has been one of the main entry points to look into inequity. And we can see that even in the most wealthy countries, you can see these same patterns of lifestyle that is not sort of conducive to cancer development, NCD development in general. So we have addressed all the the risk factors for NCD. So you can see that the socioeconomical and also other stratifying categories, you can see that tobacco use, alcohol use, and obesity is sort of still very much present.
So should we, I think we should separate this a little bit, shouldn't we? We should talk about inequalities in access, which I think is really interesting, and then inequalities in outcomes, because I think that's also really quite prevalent. Even in the UK, we've seen some really significant, not even in the UK, especially in the UK, because it shouldn't be happening, but we've seen some reports recently that have, and over the last 10 years indeed, that are showing significant inequalities in outcomes. What are the access, let's talk about the access issues here. What are the main drivers of inequalities in access, do you think?
I think it's several things. I mean, when we had the high-level commission on NCD, we got a sort of a more deep analysis. So you can see that it's difference in the political will. And actually, I think we all agree that inequity is very much driven most of all by the political will, because we have most of the means to deal with it, but it really requires leaders that are willing to invest in both health systems, in the area of cancer, of course, quality and also accessible medical devices, medicines, and so on. So that is very important, and also to actually have the ability to cost whatever plan you have and implement what we know is needed. So this is main success factors. So when we see countries that really use political will and use the best buys of WHO, we can see that we reduce already risk factors, and then as a sort of a consequence also reduce premature deaths, which is one of the ways we are measuring the outcome of the exercise.
And that's particularly, isn't it, what you have focused on is the reduction in premature deaths, and a lot of that has to do really with early interventions and also prevention, and persuading governments to have the political will to address that, or health departments to have the focus to address it.
Yes, and it's not only us. Actually, that is one of the SDGs. So it's SDG 3.4 is a 30% reduction in premature deaths. So if you look at the region, you will see that we as a region are actually able to reach that target, but only in the western part of the region. If you look at the Central Asian country and the eastern part of the region, we are way behind in reaching the targets. So then you're asking about the interventions, and we use a lot of different methodology, from investment cases to health system assessments, and of course training of healthcare personnel. So when all of this comes together, you can see that we are actually reaching a better development and the outcome that we want to see.
I suppose it's also partly about trying to understand the socioeconomic conditions that create some of the access problems, but also the outcome problems. I wonder if you could talk just a little bit about the outcomes as well. The two are linked, of course, but at the same time, there are outcome problems across income brackets, aren't there? It's not just, low and middle income countries that have those problems. It is high income countries too, as we were talking about in the United States.
It depends on what level you are discussing. I mean, if you go down to the single sort of treatment for a specific cancer, of course you have different patterns coming through. But what I have been focusing so far is really the outcome on a high level. Yeah. So, and this is the way we measure it. Of course, we measure many process indicators as well. You know, for example, are we able to see the rate of vaccination for HPV to prevent cervical cancer and so on? And we try to sort of deep dive into why we have, if this is an outcome, why we can see a development that we would like to see. And again, you know, this is linked to so many different things. And the new thing that we are focusing on to try to help ourselves is to focus on health literacy. Because to raise awareness not only among individuals but also organizations and even politicians to have the level of knowledge that make them take the healthy choices for themselves, for the population, for the organization, for the city, as I'm sure have heard about during the days on the city can and so on. This is also ways to sort of help ourselves to utilize the knowledge that is actually there.
How, we hear a lot about the variance in outcomes from health literacy campaigns. Which are the successful ones, do you think? Which are the most successful ones and why? And do they need to be supported also by strong government intervention? We heard earlier about intervention around sugars and intervention certainly around tobacco, but certainly sugars is another area. What makes a good health literacy campaign?
So you can never have health literacy as a campaign alone. I mean, so that's the point. I mean, health literacy is very much about co-design and sort of using multi-stakeholders to design the solutions. Yeah. So I think excellent examples, for example, to prevent childhood obesity, which is the really starting point to prevent NCD and cancer, we can see from Portugal, for example, where all different stakeholders join up together, from media to the private sector to the government, but of course it has to be led by government. Or the recent example, which is extremely compelling, from Russia, really being able to reduce alcohol consumption over the last years. Or in Ukraine, where we have had a significant reduction of tobacco. And these things are not, I don't think any of these interventions is possible to do as a sole kind of health intervention. It has to be an uptake in all the different sectors. It has to be sort of an ownership from the different stakeholders to be able to do this.
It has to be health in all policy, doesn't it? And indeed health across the public and the private sectors, not just the public sector.
But one of the places we are not able to still, I think, really see good results is in the area of medicines and the sort of the market, the whole supply chain. So I think the next step, and especially linked to cancer, is to really look into both to have access and quality, and also to, again, look at the health costs and the insurance schemes and link it to the universal coverage. So I think the universal health coverage agenda will give us completely new opportunities to look into benefit packages, and also to do more deep diving analysis to the whole question of inequities.
Bente, thank you very much for that sort of setting the scene there. I think it's a really, really helpful. And let's jump to Carmen, and let's talk about access in the context of the Philippines. One of the things that you have felt, and indeed other groups, NGOs, and indeed politicians in the Philippines have felt it necessary, is to drive the passage of legislation around cancer. Can I ask you to give us a little bit of the background there? I mean, my sense, of course, is that part of this is the frustration that you've had with the lack of progress on national cancer control within the government and within the Department of Health particularly.
And I think what makes it even more interesting is that we also have just passed the Universal Healthcare Law.
Yep.
So then people would say, you already have the Universal Healthcare Law, why did you have to parallel go through the cancer law as well? Yeah. And really the reason for that was, we felt when we saw the initial draft of the Universal Healthcare Law, that cancer was probably not going to be given the priority and the focus that it required, because in the early language of the Universal Healthcare Law, it was speaking only of basic medicines as well as basic care. And when it comes to cancer, we always use the word catastrophic care and more complex care. And so because of that, 8 of the biggest cancer-focused organizations in the Philippines decided that rather than just amplifying the specific disease streams of cancer, to come together, form the coalition, and recommit for having a cancer law that will meet the needs of all cancers, all stages, and all ages. Mainly because, again, in the country at that time, all of the policies that we had were covering and providing medical support only to those up to stage 2. And we felt, alongside the WHO guidance that was provided, as well as the WHA resolution, which actually became, for us, a very important document that we brought to the ministry and to the legislators to be able to convince them that there was wisdom in having a separate law for cancer. The other thing as well is one of the legislative icons in our country says that coming up with a piece of legislature is like coming up with poetry. He says, first you have the interest to do it, then you need the inspiration and the information and all of the interactions to really push it through. And I think what happened with both the UHC law and the cancer law was that there was interest both within the ministry. In the ministry, the UHC is their baby. Yeah. They started it, they taught it. 10 years ago, there was already a study as part of the health sector reform agenda where key academicians and thought leaders identified what was wrong with the health system and what needed to be done. Even before that, 25 years ago, we had our what is known as PhilHealth, which is essentially social health insurance. So this year, it was like trying to put the pieces together. When it came to the cancer law, the inspiration there was not only did we amplify the voices of patients, families, survivors, but we also identified legislators, both in the upper house and the lower house, whose lives had been touched by cancer. Either they had a family member who was going through the cancer journey, or they had lost a loved one. So many of our most effective and most vocal legislators were people who had already experienced it personally and knew how difficult it was, even while they were better off than the regular Filipino would be.
So it's really interesting that both the Universal Health Care Law and the National Cancer Act are passing through at the same time. One of the challenges that this has posed is that the Universal Health Care Act, which is sitting under really the Department of Health, and it's really a government initiative, is clearly, I suppose I say this hopefully not too in too sort of stark a way, but there is a conflict, a tension between their perspective of what needs to happen to build universal health coverage in the Philippines, which is very necessary and very important, and the need on the part of those people that feel cancer is underrepresented in the healthcare universal health coverage program and underfunded, for you to be pushing through a National Cancer Act for that to happen. So how is that tension going to be resolved? How is that going to be resolved?
Yes, there was that tension. Also because in the beginning, the Cancer Act was getting more traction in the legislative houses than the UHC was.
Can't have been
mainly because, as I said, you know, the legislative champions had made commitments to a mom, to a wife. The health committee chairs were very much behind it. For the first time, we had 258 congressional people signing off to an act, even if it was still in the process of being developed. And also because every time there would be a meeting, we would make sure that the room was overflowing with patients, families, and so on. And there would even be instances we're supposed to be at the end of a very long agenda of the legislators, and then they would look around and they would say the kids, you know, with the mask and so on, and somebody would stand up and say, could we please move and have the Cancer Act on number 2 rather than number 15? So it was also this whole energy. Somebody was saying earlier about it's a political choice, and we need to make sure that it's not just the political will, but the action. I think we saw that in our country. At a certain point in time, well, we are a constantly evolving country in terms of leadership in our Ministry of Health. So we had the Ministry of Health who had sat with the executive board of WHA, was involved in WHO resolution, had put the cancer law as a priority bill. And then she was changed. And the second one was more of the UHC and not, so there was a point in time when they even told the legislators there should be no cancer law. That should not be supported. But again, because there was so much support from civil society and media and all the different stakeholders, it continued in its own stream. And so parallel, we're now friends. We don't see each other as competing with each other. We feel that there is a role for each of these laws.
So, I mean, that friendship, how did you rebuild that relationship? Because I think it's important here, because effectively the Cancer Act mandates funding and mandates a national cancer control program through the Department of Health, ultimately. And so you've got to, ensure that the relationship between the Universal Health Coverage Act and the National Cancer Act is friendly and is amicable and indeed works. I mean, more than amicable, it needs to work.
Yes, I agree. And there were two steps that we took and two factors that were very positive in our country. One, the president of the Philippines has a special connection with kids with cancer. Yeah. And as well, his partner right now is a nurse. So we actually sought an audience, first with the partner, but the president was there. He works late at night, and he said, how come you didn't ask to speak to me, just to my partner? And then when we explained to him the quagmire that we were going through, he called a special meeting of a special body that usually doesn't just meet, and cancer was there on the agenda. And then secondly, the legislators themselves called the Ministry of Health at a point when they were defending the budget and said, so what is this we hear that you're not supporting the cancer law, which we had all passed as a priority?
So it's really fascinating, isn't it? It's really very political at the end of the day,
yes.
And it requires political will from high up quite often to be able to move some of these things. Yet at the same time, it's created some tension and some conflicts which you need to resolve around it. The other thing that I think is really fascinating about the Philippines is the way in which groups such as yours have managed to focus the minds of people to drive through legislation. Can I ask you, I mean, do you think legislation, I think a lot of people in this room may not feel that legislation is necessary to drive through cancer, a cancer control plan that works?
We have been very patient through the years where there have been administrative orders. These are like policies that have been issued in terms of cancer. And we've been very hopeful as well. And in fairness to the government, there has been some improvement, especially in terms of access to medicine. But in terms of integrated care and health systems strengthening, that has not been something that has been approached the way that we would like it to. And so we felt after about 3 administrative orders that were good on paper but never got implemented or got swept aside because there was a change of government, that only a law would ensure sustainable funding and sustainable support for what was needed for more cures, increased survivorship, and really a better future for everyone who's facing cancer, so that it's no longer a death sentence, it's just a disease that we can all fight together and conquer.
Carmen, thank you. Thank you very much. Jeffrey, private sector and the role of the private sector. I think this is the other dimension that we can be looking at. Sorry, my apologies. Thank you. Obviously, at the high-level meeting at the UN, we heard that the emphasis on the need for greater public financing and the estimation by WHO of the gap, the funding gap that sits there, 370 billion per year from now through to 2030. I wonder what you think the role of the private sector, and we started to touch on this a little bit earlier, what the role of the private sector is in helping to address that gap.
Well, thanks, Charles. I think the first thing I would just say directly is the private sector has an absolutely critical role to play in helping countries on the path to universal health coverage. Just to step back for a minute and comment on what Carmen and Bente said, I think it was the story that Carmen told about the way that a political coalition came together to really encourage the government to act is a good example of how every country is going to find its own path there. Yeah. Every country has a different set of political, economic, social, technical needs and capabilities. And so universal health coverage is not going to look the same in every country until we have the final result, which is everyone is covered without risk of financial catastrophe. And in that context, I think it's going to be important for us to start thinking differently. You know, you mentioned this funding gap that WHO has estimated, which is going to be roughly $4 trillion over the next decade of money that needs to be mobilized in order to help countries fill the gap in building primary care, which a year ago, as the minister mentioned earlier, here in Astana, the declaration on primary health care provided a roadmap to what countries have to do for that pillar of universal health coverage. But then the other $170 billion is to help fund the gaps in the essential package of services that countries will need. But $370 billion sounds like an awful lot of money. It's actually almost 10 times the annual amount of development assistance for health that's now available to lower and middle income countries. So thinking that we're going to find that kind of money with the existing relations among donor countries and their partner countries is unlikely to lead us to universal health care. And what we'll have to start thinking about is where are other resources, how can they be mobilized? And that's where, if you look at estimates that have been made of the total amount of money that is spent globally on healthcare every year, that's more like $10 trillion. So the 370 billion is less than 4% of the total amount that the world spends on health every year. So the question is how to move from what we usually see, which is political won't, to political will, to reallocate those resources in a way that will help countries achieve universal health coverage. One of the ways to do that, I think, is to look at how the private sector can really help work with governments and civil society to get there. So I'll just make 3 quick points about that. First is that it's not a question of whether the private sector should be involved, but how to manage, to motivate, to encourage, and to account for private sector engagement in helping countries to get to universal health coverage. In many countries already, anywhere from 30 to 80% of healthcare is delivered for or paid for through the private sector. So countries need to find ways to work with those resources. And of course, governments have to be the stewards of that. There's a need for regulation. It's not the Wild West, but there's much that the private sector can do. And they bring more than money. They bring capabilities, they bring creative innovations and collaborations and new partnerships, all of which help build a stronger health system and also which need to be tailored in ways that are adapted to the needs of individual countries.
So one of the challenges there of the private sector would strike me, and just being around some discussions in Asia, particularly around the challenges that governments have, the public sector has in engaging the private sector in and around healthcare, is that there aren't simply the protocols in place within government to be able to properly regulate that process, it seems to me. Is that a challenge that you come across quite often?
Oh, sure. And actually, that's one of the elements of the political declaration that we talked about earlier. It actually calls for having multi-sectoral collaborations to establish the rules of the road. So that's certainly part of what has to be done. And there are plenty of good models around for how governments can work with private sector partners, with others in civil society, to focus on areas where there's common ground and to find ways to work together on a common goal that will lead to better health outcomes.
So it'd be really good, I think really helpful for everybody if you were able to give us a few examples of some of those successful public-private relationships where the private sector supplements what the public sector is doing.
Well, actually, one was mentioned earlier, and I think a good example that's particularly relevant for this audience is the City Cancer Challenge, because that's an example where UICC first conceived of and incubated the City Cancer Challenge. And as we heard briefly earlier, it's an example of where cities led by the city government have put together multi-sectoral committees to think about what do cities actually need to achieve better cancer outcomes. And then working together with the private sector, with civil society, with the government, to find the resources and to implement the programs they need to deal with the problems that each city faces. So that, it's still in early stages, but there are already cities in Latin America, Asia, and Africa that are beginning to move along that path, and it'll be interesting to see how that develops. And one of the partners, there are many partners in the City Cancer Challenge, but they're working with Access Accelerated, which is a consortium of about 24 pharmaceutical companies who are committed to helping improve outcomes for chronic disease, and they're one of the collaborating partners in the City Cancer Challenge.
So we spoke a lot earlier about some of the financing challenges that are presented to governments that need to, in effect, supplement their funding for universal healthcare. What kind of, appropriate models of private sector financing could be utilized, do you think, to raise the public, to raise effectively the ability of public sector organizations to deliver universal healthcare?
Well, I think the way I look at it is that there's not, most of the discussion around financing of healthcare has started from the premise that healthcare should be a public function which should be financed by the public. Yeah. But as we've heard from several examples in the discussion today and yesterday, most countries have difficulty finding enough money to fully support what they need to do in healthcare coverage. So one way of looking at it is, you can find more money through sin taxes, you can tax people more, you can have mandatory social insurance programs through employers. Those are all ways to raise money. But politically, you get to a point where people are loath to spend more money because they feel they're not getting the services that they expect for the amount of money that they're paying. Yeah. But there are other sources in the private sector where there are investments being made all the time in healthcare, and the way that I think to look at it is to have a mixed system in which you're using both public and private resources, and the private resources can complement what the public is doing. So for instance, we see examples where, the UK is a good example. People who can afford it will top up their NHS health insurance, or health coverage rather, and that takes pressure off the system so that the NHS can focus more on people who can't afford to top up their coverage, and and that does lead in a certain way to better coverage for all. And similarly, in other countries, that's also possible. In the U.S., where I come from, there's a lot of public financing for the elderly and for the poor. Most people pay for health care through their insurers, through insurance coverage through their insurers. It's not a perfect system, but it really takes advantage of competition within the private sector to keep some costs lower than they would be otherwise, and to ensure that the money the public sector has goes to help those who can't help themselves. We've made progress in the last couple of decades in lowering the number of people who are uninsured by a significant amount. So those are just two examples, but I think the general principle is that a mixed health system that takes, that uses all of the resources that are available and all the expertise that's available is likely to lead to better health outcomes in the long term.
Jeffrey, thank you. Let's move on to Dr. Jemal. Your presentation, please. Oh, here we go.
Okay. So I think, so I'm gonna just provide an overview of, or a brief talk about the third edition of the Cancer Atlas that we launched today at noon. And the theme of the Atlas is Access Creates Progress, specifically with emphasis on public health policies. So the Atlas is a comprehensive and evidence-based overview of global patterns and inequalities in major risk factors, cancer burden, and also the application of known interventions. And it's the Atlas target audience include cancer control advocates, policymakers, public health professionals, survivors, in order to promote cancer prevention and control locally, nationally, and globally. We published the second edition of the Cancer Atlas, accompanied by interactive website in 2014, and the Atlas was translated into 9 additional languages and also widely accessed throughout the world, specifically the online version of the Atlas. So based on the success, we updated and published the 3rd edition of the Cancer Atlas with up-to-date data on information across the cancer continuum, and we have also 3 new additional chapters, including cancer in indigenous population and universal health coverage. Also, we improved the website, say that it is shareable on social media, and also you can download the figures and the maps. And also throughout the book, we added success story of public health policies under headline Access Creates Progress. So I'm going to just give you highlights of the Cancer Atlas. According to GloboCan, which is data from IARC, from Freddie and his group, the estimated number of new cancer cases yearly will rise from 18 million in 2018 to about 29 million in 2040, a 60% jump. This is just simply because of the aging and growth of the population. And with the increase, as you can see, greater in low and middle income countries. And in fact, when you consider the additional expected number of cancer cases because of the increase in prevalence of major risk factors like obesity, physical inactivity, unhealthy diet, this number is actually underestimated. And for example, more than 1 in 3 women in North America and in East Mediterranean region, as well as in South Africa, are obese. And we haven't seen really the full impact of obesity on the cancer burden. What is more is now cancer is already the leading or the second leading cause of premature deaths in most parts of the world, except for sub-Saharan Africa countries and the part of Asia. But as we discussed this morning, I think a substantial proportion of this premature cancer disease could be averted or prevented by implementing resource-appropriate intervention in each countries. So I'm going to give you, the reason I say is that because most or all, I should say, leading cause of cancer deaths, such as lung, liver, colorectal, lip and oral cavity in men, and breast, cervix, again, lung cancer in women, are amenable to primary prevention, early detection, or treatment. So what I'm going to give you is 2 examples that we highlighted in the Atlas as parts of Access Creates Progress, specifically on public health policies. The first is something that already Carmen said, but this is slightly dated data, which is the increasing excise tax on tobacco in Philippines. In 2013, the Philippines government raised the minimum tax per pack of cigarettes by 4-fold from the 2000 level. This was associated with reduced smoking prevalence, which saves hundreds and thousands of lives. But more importantly here, actually the government used this additional tobacco revenue to expand healthcare coverage for low-income families and improving healthcare infrastructure. The second example is excise tax on sugar-sweetened beverage in Mexico. The Mexico government raised sugar-sweetened beverage by 10% through tax beginning January 1, 2014, and this resulted within the first year of tax a 6% decline in purchase of sweetened beverage, while a 4% increase in purchase of unsweetened beverage. So our hope is that some of the examples that we show in this atlas will motivate action in some low and middle income countries. So we will translate the atlas into 5 additional UN languages, and if anyone is interested in translating the atlas into additional language not listed here, you can contact Shanali Johnson of UICC or Kristen Salt of ACS. And this product is really a contribution of many people and organizations. I would like to acknowledge the contribution of my co-editors, Freddie and Isabella from IARC, and my colleague, Lindsay Torrey, and also, of course, the authors of the chapters and reviewers whom I have already seen at this meeting and who may be also in this audience, and John Daniel and Rabia Khan with assistance, editorial assistance, and Shanali and Kristen Sol for promotion and translation. And I would also like to thank ACS, IARC, and UICC for their financial and material support. So the atlas is already live, so I would encourage you to explore the atlas online, and I would appreciate it if you would share the URL with friends and colleagues and family members. Thank you.
Thank you, Dr. Jemal. Excellent news, great news, and well, congratulations on all the work's done. Make sure everybody you log on to that particular site and have a look. Do please join me in thanking Bente, Carmen, and Jeffrey, and of course Ahmedin for a very interesting session. Thank you very much indeed. Thank you.